Good morning, everyone. So I actually talk about the spectrum on the other side, where actually you have to manage the patients where the MIS has actually gone bad. So topic is portal hypertension and secondary biliary cirrhosis in post-cholecystectomy benign biliary strictures, its cause, the management, and the final outcomes. Yeah, thank you. So I have no financial conflicts to disclose. So in a still not working. So in a global data report of March 2023, you can see that more than 3 million patients actually underwent laparoscopic cholecystectomy in 2022 alone in India. And if you take the literature incidence of bile duct injury of 0.3 to 1.2%, the magnitude of the problem hits you like anything. So majority of these patients actually present to us late because of multiple factors like delayed referrals, then primary repair being tried, or sometimes even lack of means or distance. And most of them could have higher grades of biliary stricture at more than grade 3. And portal hypertension, if present in these patients, can portend a difficult surgery and eventually can lead to poor outcomes. So to bring things to perspective, these are the 45 patients which saw in last 1 year itself, out of which 40 patients of primary biliary stricture were there. And you can see that more than 85% are actually complex strictures. And 5 patients of hepatogenostomy stricture who had initially undergone a primary repair elsewhere. So we analyzed our prospective database over the period of 15 years. Predominant surgery was Roux-en-Y hepatogenostomy with liver biopsy. Few patients undergoing redo hepatogenostomy and hepatectomy as well. We compared the pre-op, intra-op, and post-operative parameters of these patients. So morbidity and mortality was noted, and the long-term follow-up was actually graded with McDonald grading, and grade A and B were considered to be good outcomes. So total 613 patients over a period of 15 years. Although the percentage is only 3% in this study group, over the last 5 years, we have reanalyzed and we've found that the number has actually increased to up to 8 to 10% now. The median follow-up of our study was about 54 months. So in preoperative imaging, you can see these are the patients who had type 4 benign biliary strictures, or this is a patient who presented to us with recurrent cholangitis with HJ, and we found there was a stricture at the hepatogenostomy site. Then most of these patients with complex strictures underwent PTC and then underwent a PTBD gram, and these are the images of type 3, 4, and actually 5 benign biliary stricture. So intraoperatively had findings like an internal biliary fistula. You can see there is a PTBD in situ in this patient, and you can see the adhesions all around, and the coagulopathy that is there can lead to more bleeding. Then these are the patients who can have atrophy, hypertrophic complex. So if there was a PTBD, like bilateral PTBD, we actually utilized them as internal and external stents, and then formulated a single large anastomosis in these patients. Sometimes we actually did not have PTBD, so then if there were 2 ducts, we did take the help of an intervention radiologist and did a retrograde cannulation, and then again achieved a single wide anastomosis. So this is a picture of a hepatogenostomy stricture actually presenting to us, and you can see it has almost turned into a pinpoint stricture. And so this is when we dismantle this hepatogenostomy, you can see that after the dismantling, there is hardly any flow of bile, so which means that it has completely strictured. So then what we did is we did an intra-op ultrasound, took the help of intervention radiologist, cannulated the duct, laid it wide open. Then we did an intra-op choledocoscopy and made sure that all the ducts were actually incorporated in the single anastomosis and achieved a wide anastomosis for such a patient. So eventually this patient is actually now symptom-free. So lately, we have also done a lot of hepatectomies in patients with benign biliary strictures. It's a very difficult task with a lot of periductal fibrosis with the portal vein. But if you can achieve a good control inflow and outflow, you can do hepatectomies and do a left hepatogenostomy. Not all patients undergo external stenting. Total hepatectomies till date is 24, and the largest reported in the literature is about 18. And these are the histopathological features showing intraductal cholestasis with regenerative nodules and inflammatory infiltrate. So on comparison of these two, we found that there was delayed presentation in almost both the subgroups, but the patients with portal hypertension had a very, very delayed presentation. They were more likely to have a failed primary repair. The mean operative time was expectedly more in patients with portal hypertension. Similarly, the median blood loss. Morbidity, although was higher in this subgroup, but it did not achieve the statistical significance. Median hospital stay was also higher in this patient, but this was predominantly due to higher drain output, hypoalbuminemia, and could be managed conservatively. But when we compare the long-term outcomes of these patients, you can see that even after undergoing a Roux-en-Y hepatogegnostomy, the long-term outcomes are actually comparable in both the groups. And actually, we have seen that in follow-up, when we have done liver biopsy of few patients, there has been actually a reversion of the fibrosis that was there. So in conclusion, I would say that delayed repair, higher grades of benign biliary stricture, and failed primary repair are the significant factors which would be associated with a secondary biliary cirrhosis and portal hypertension. But with a meticulous approach, a Roux-en-Y hepatogegnostomy without the need of a portosystemic shunting or a hepatic resection is possible. Until date, only one patient has come back to us in which we have done a revision Roux-en-Y hepatogegnostomy again. We haven't done a hepatic resection till date to any patients, and we have a very robust follow-up, and none of the patients have shown decomposition also. Thank you.